acute respiratory distress syndrome. It's a severe condition. It is life-threatening. When there's not a pandemic, there's about 200,000 patients per year that contract ARDS or that go into ARDS. There's about 75,000 deaths per year, and the mortality is 35 to 45%. So it's pretty high. But with COVID, that's of course upping the numbers, because people that get COVID-19, all the ones that are going to the hospital and are really sick, are going into ARDS. In general, before the pandemic, it accounts for 10% of the ICU admissions, and about 24% of people that are on mechanical ventilation are dealing with ARDS. So this is a pathophysiology that you will see a lot. And there's a couple of different etiologies. There's a pulmonary etiology and a non-pulmonary etiology. So when we talk about pulmonary, that's from a direct insult from the lungs, such as pneumonia or aspiration. And when we talk about pneumonia, remember there's viral, there's bacterial, there's fungal, there's community acquired, there's nosocomial pneumonia. So any type of pneumonia or any virus. So really COVID-19 would be a pulmonary etiology of ARDS. And then a non-pulmonary reason or etiology for ARDS would be sepsis, pancreatitis, or trauma. And sepsis can be from, remember, sepsis is just an infection that gets into your blood and goes through your whole body. And that happens with any type of infection, not just a pneumonia type infection. Pancreatitis is when your pancreas isn't working and your body's really not able to get out the toxins and absorb the nutrients it needs. That takes a big toll on the lungs as well. And then trauma, like your motor vehicle accidents, anything that causes a direct insult to the lungs. Pathophysiology is non-cardiogenic pulmonary edema. So remember, when we had our patients with cardiac failure, that means they either had CHF or they had an acute myocardial infarction. Perhaps they had a pulmonary embolism. They had something that the cardiomyocarditis, anything like that arose from the heart. In non-cardiogenic, we're talking a lung issue. So it's the lung issue that what happens, it creates the alveolar capillary membrane to become permeable. And when we mean permeable, it means water and red blood cells or things that shouldn't be able to go through those channels sneaks through. And in that case, it has a lot of fluid that builds up inside of the lungs. And then inflammation takes place due to all the chemical mediators that are released. So now you have heavy, stiff, wet lungs. And what that does is that impairs gas exchange, leading to patients being hypoxemic. The clinical presentation, people end up with hypoxemia, tachypnea and dyspnea, opacities on imaging, decreased lung compliance, so the lungs do not accept a tidal volume without a lot of pressure. Decreased lung compliance, we just said that, increased venous admixture, and an increased physiologic dead space. So what an increase in venous admixture is at the alveolar capillary membrane, you have oxygenated blood. And if the lungs and diffusion are working okay, your partial pressure of oxygen should be around 100. And then when the blood goes to the tissues eat the oxygen off, and then it comes back deoxygenated at about 40. So what happens when you have venous admixture is just when there's not enough oxygen that gets through the blood through diffusion, then you just have a lot lower percentage of partial pressure of oxygen. So that's what we mean by venous admixture. And then a lot of physiologic dead space. So there's areas where the lungs are accepting some volume, but there's no gas exchange taking place around those. So by definition, there's four pieces, and this is also in page 911 in your HES book. So the injury itself has to be acute. Acute meaning it has to happen within 1 week. So a patient with like if they contract COVID, they become symptomatic within 5 days. So they'll start seeing increased distress, hypoxemia, just the shortness of breath. And then it's usually about day 10 where they're at the peak or the worst, and where a lot of times they do go into ARDS. This cannot be explained from a chronic condition. It's within 1 week of whatever injury is happening. What happens is there's bilateral opacities, and that's, of course, from the pulmonary edema. So if somebody had like a lung tumor, you couldn't say that they have ARDS. It has to be, or same with one consolidation from pneumonia. It has to be affecting both sides. And then there cannot be any evidence of left ventricular failure. So therefore, the pulmonary capillary wedge pressure should be less than 18 millimeters of mercury or torr, meaning there's no cardiac causes. Now, when people come into the hospital, you're not going to say, okay, well, we really need to put a catheter in to decide if this is coming pulmonary or cardiac. Take, for example, the COVID patients, you know what that's from, okay? That's going to be a lung issue. The problem is going to be a non-cardiogenic problem. And then refractory hypoxemia. So if we remember, this PF ratio is going to be absolutely crucial to understanding oxygenation and ARDS and being able to classify it. So PaO2 over FiO2. When we do that, if you guys want to get your calculators out and follow along, you're more than welcome to. So right now, if I were to measure our blood here in Denver, and we have a PaO2 of 80 torr, and I think all of us are only on room air, so that's 21% for FiO2. We would say 80 divided by 0.21. Did anybody actually do the calculation? That's fine. I'll tell you what the answer is. It's 381. So a higher number is better when we talk about our PF ratios. So if we have a PF ratio between 2 and 300 with a PEEP or a CPAP of 5 centimeters of water pressure or more, we can classify the people and say they're in mild ARDS. If their PF ratios are between 1 and 200 with the PEEP CPAP of 5, then they're in moderate. If they're less than 100 with their PF ratios, then they're in severe ARDS. So here's an example. Now, you will notice an error on the last one, but if you look at a PF ratio, a PaO2 of 100, in the patients on an FiO2 of 50%, 100 divided by 0.5 is 200. If a patient's PaO2 is 90, but yet they're on an FiO2 of 100%, 90 divided by 1, the ratio is 90. So this patient would be classified as mild, and this patient would be severe ARDS. And this is a mistake. 100 divided by 0.5 again is 200 again. I'm not sure why I left that on there. Sorry about that. So do PF ratios make some sense?
So higher is better, right?
Yes, higher is better. That's absolutely correct. So right now we're probably sitting at about 380, something around there. And these patients, 200 to 300 mild, 100 to 200 moderate, less than 100 severe. Okay, imaging. So I really liked your scavenger hunts that you guys uploaded. Those I think were really helpful. But you can notice here that this patient has bilateral opacities, and they're really hypoinflated. Okay, so when there's little white speckles like this, that is not air. That's actually fluid. And this here is a CAT scan. And I want to point out a couple of things with the CAT scan. Of course, to get a CAT scan, someone has to be in the supine position, meaning laying on their backs. And if you look here, we have the heart. Here's the vertebral column. This would be our sternum or our ventral cavity up here. So this patient has a lot of fluid inside of their lungs. Okay, and the fluid is gravity dependent, so it sinks to the bottom. One of the things that's really helping ARDS patients is if you flip patients prone. So if you flipped them upside down, what would happen then is the heart would not compress on the lungs. And look how much more surface area. Look at how much more surface area in the posterior side they have for oxygenation and ventilation. Okay, so if you prone the patient, that really helps them with their outcomes.
Is that why a lot of COVID patients are in a prone position?
Absolutely. That's been one of the only things that's been helping them, putting them on a ventilator, putting them prone, and a lot of times paralyzing them as well. So yeah, they've been saying PEEP and prone, meaning increase their positive end expiratory pressure, which we'll talk about, and keeping them prone. In addition to the heart, when patients are in the supine position, there's a lot more abdominal pressure just from the abdominal contents. And then also, if they're obese, then there's even more body weight that's compressing the lungs, causing even further restriction. So keeping them prone is a very good thing to do. Here's another image of a patient with ARDS. And just, do you see all of this haziness? All of that is just extra fluid that should not be there. So managing patients, now we're going to do our best to talk about mechanical ventilation. We're going to continue to talk about that, even though just know that all of next year you'll have to learn about mechanical ventilation. We need to have an understanding of it now so we can build upon that knowledge. So with management, treating the underlying cause right away. So, you know, if they were in a trauma, you know, they might have a pulmonary contusion or a head injury, so work on that. If they have a bacterial pneumonia or sepsis, giving them antibiotics. Then supporting oxygenation. So we support oxygenation by giving oxygen. So we can put them on a nasal cannula or a non-rebreather, and if that doesn't work, then we can switch to heated high flow nasal cannula, but then we'll probably end up having to ventilate them. So supporting their ventilation through mechanical ventilation. Also, supporting their cardiac output is another major aspect of treatment. So when we look at this next slide, it's the overview of oxygen delivery. So at the top up here, DO2 stands for delivery of oxygen. If we can remember what the equation for that is, DO2 is our cardiac output times our content of oxygen, our CaO2. So if we break down all those components, DO2 is made up with our cardiovascular system and our lungs. So through the cardiovascular system, the main components of that are our blood vessels, our heart, and our blood. And our cardiac output is made up of our stroke volume times our heart rate. And stroke volume is made up of afterload, contractility, and preload. So when we say support our cardiac output, that means to help preload, we would give fluids. To help contractility, we could give a positive inotropic drug that would help our muscles contract stronger. And then our afterload is how much our blood vessels are constricted or not constricted. So it's the vascular resistance in our vessels. So for afterload, we could give a vasodilator that would help open up those vessels and allow the blood to move through easier. And then as far as our lungs, that is our lungs' ability to bring in oxygen from the ambient atmosphere and then attach to our hemoglobin. So of course, from our blood, we need to have hemoglobin to be able to have a good content. And if you guys remember, the content is the combination of both the oxygen that is dissolved in plasma and attached or bound to hemoglobin. So it's the hemoglobin times the 1.34 times your SaO2 plus your PaO2 times 0.003. So my point to this is all of these functions have to be working appropriate, or patients aren't going to have enough DO2 for the tissues. And if you don't have enough oxygen to the tissues, that's when we start going into anaerobic metabolism, and that's where our organs start to fail. So we can help provide respiratory support to our ARDS patients. And remember, ventilation is measured by PaCO2, and you obtain that by taking an arterial blood gas. Carbon dioxide is a waste product of metabolism. So if we have a patient that's septic or fighting an infection, that metabolism is going to go up, and the carbon dioxide level is also going to go up. Do you guys remember what the normal PaCO2 is? The normal value? Anybody want to take a guess?
35 to 45?
Absolutely.
Yeah.
So if our PaCO2 is greater than 45, we call that hypercarbia, and that'll cause an acidosis in our body. If our PaCO2 is less than 35, we term that hypocarbia, and that leads to an alkalosis in our body. And we treat hyper and hypocarbia with changes in mechanical ventilation. Our oxygenation is measured by our PaO2, and we obtain that with an arterial blood gas. Our SaO2, which is the saturation of our hemoglobin with oxygen, that's also measured via arterial blood gas. And then our CaO2 is a calculated value. And once again, you have to find out the patient's hemoglobin value. You multiply that by 1.34, multiply that by the SiO2, and then add in your PaO2 times 0.003. Oxygen is extracted from the ambient environment, and when there is not enough, we term that hypoxia, and we treat with oxygen and PEEP, positive end expiratory pressure. So here are a couple of devices that we could use that'll help us to treat with oxygen and ventilation. The first picture is a heated high flow nasal cannula. And so this lady's enjoying some nice oxygen. Rather than like 2 to 6 liters, you can put this all the way up to 60 liters per minute. But it also, therefore, is then humidified and heated, so we don't create a humidity deficit in our body. The picture next to it is a Philips V60, and this is a non-invasive ventilator. And you notice this lady has a mask on her face. So one of the things right now with COVID is really the protocol is going from oxygen. You can use heated high flow nasal cannula, but you do not want to use this non-invasive ventilator. And the reason for that is because you notice there's just one, what we call a single limb circuit. And so do you guys remember when we tried this in class and there was a little hole and it blew out air and it like fluffed up our hair, and it was nice to have all that flow coming at us? Well, you don't want to do that. That's like aerosolizing the virus into the air, turning it from a droplet to an airborne transmission. So absolutely go from the heated high flow nasal cannula, and if those patients are still having a low PF ratio, they need to be intubated and mechanically ventilated. So keeping fluid balance, we definitely want to give the patients fluid to optimize their cardiac preload. So you can give normal saline, you could give a colloid fluid with albumin, which is a protein, which will increase that oncotic pressure and try to prevent some of the interstitial fluid to get out of the interstitial spaces and prevent that from going into the to the lungs. Or you can give crystalloid, which is kind of like a Gatorade. It's got electrolytes and calories in it. And then to help with patients' cardiac output, giving them an inotropic drug to increase the muscle contraction. And then even though you're giving them fluid, you're also giving them diuretics to try to get out the extra fluid that's in their, like in their lungs and their interstitial spaces and hanging out in their dependent areas of their body. So it's definitely a balance to keep these guys managed. And then we also want to give a vasopressor, and these work on selective receptors in the sympathetic system. And what these do is these actually will increase your afterload or increase the resistance, so it'll increase your blood pressure. So common ones are dopamine, norepinephrine, epinephrine, phenylephrine, and vasopressin. So all of these will increase your patient's blood pressure. Common ones are dopamine. Almost all your patients in the ICU are on dopamine. And then if they're going into shock because they're not getting enough delivery of oxygen to their tissues, norepinephrine is the first treatment that's given. Okay, mechanical ventilation. So we are going to talk about this a little bit. So VCV or PCV stands for volume control or pressure control ventilation. So what that means is the ventilator is going to give a breath and it's going to stop giving a breath if you put it either in a volume setting or a pressure setting. You want to target low tidal volumes here. And if you guys remember, you and I are just sitting here, we're hanging out, we're probably, listening to me talk and we're reading our books. And do you guys remember what the normal values for our tidal volumes are?
I cannot remember to save my life right now.
Okay, just a minute here. Okay, so if you guys remember, we talked about we would give tidal volume in mils per kilo. So we had about 4 milliliters, 4 to 6 mils per kilo. Okay, so just remember how many kilos are you? Multiply that by 4 to 6. Okay, so I have a nice little chart here. It's kind of hard to see, but we do predicted body weight or body volume based on people's height. So somebody tell me how tall you are. Anybody in the class?
I'm 5'5".
You're 5'5", Irene. Thank you. So I'm looking at this scale right here. Okay, so it says, you guys see that at all?
Yeah.
There, 5.5. Okay. So now that you should be about 57 kilos based on that. The low amount of your tidal volume would be 228. All the way up, you could give all the way up to 456 tidal volume. So that's what we call our predicted tidal volume. So you want that between 4 and 6 or 6 to 8 mils per kilo. Okay, so anywhere between 4 and 8 mils per kilo.
Okay.
Okay, so just think of her Irene's size. Remember, as you get taller, your volume goes up. So we would probably start Miss Irene about 342 milliliters for every breath. Okay.
And you can do that on a mechanical ventilator?
Yes, ma'am. You sure can. So with ARDS patients, because they have such non-compliant, heavy, stiff lungs, you want to target a lower tidal volume. You want to give them high PEEPs, but when you give a high PEEP value, you want to watch the cardiac output and the blood pressure, because when you give a lot of pressure in the intrathoracic pressure, it can compress the heart. You want to give them sedation to enhance their ventilator synchrony. Because if you put you and I on a ventilator, you would really naturally be wanting to fight against it. And then you may even want to paralyze the patients if they're severe. Their PIPs may be high due to that low compliance, so you want to monitor that. And then the plateau pressure should not go above 30, and the plateau pressure is our alveolar pressure. So when we give mechanical ventilation, we increase the average airway pressure, our mean airway pressure in our thoracic cavity, which puts pressure on that endothoracic cavity, which presses against the heart, especially the right atrium, and that can decrease the blood that comes back into the right side of the heart. And when you have a low blood volume, that doesn't deliver enough oxygen to the tissues, and that's how patients go into multi-organ failure. And as you can imagine, multi-organ failure does not correlate with good outcomes.
Correct.
All right. So you guys did your assignment and you guys read about how ARDS first got described here at University of Colorado Hospital. And do you guys remember that was back in the 1960s, really about the mid 1960s. That's when we started ventilating patients and giving them PEEP before they thought, oh no, that's going to hurt them. Well, that's the only thing that's saving them. So between the 60s and then, for like 20 years between the 80s and the early 2000s, they did what's called the ARDSnet study. And they looked at a lot of patients and really said, how are we going to make these ARDS patients live? What's going to give them the best outcomes? So we now know that when we're setting up our ventilator, we have to really use low tidal volumes. So like that little chart I have, or next year you'll learn the calculation. So what you'll do then is you'll set your initial tidal volume to approximately 8 mils per kilo, and then you're going to watch your alveolar pressure. And if that's too high, then you're going to go down to 7 mils per kilo. If it's too high, you're going to go down to 6 milliliters per kilo. If it's still too high, you're going to go to 5 mils per kilo and then 4 mils per kilo. So we start at 8. Pretty quickly, we'll probably end up at 6. And they've shown that 6 mils per kilo is associated with the best outcomes with ARDS patients. You want to set a higher rate as long as it's less than 35 breaths per minute. That's fine. Our recommendations with the COVID ARDS patients are setting them at a respiratory rate about 25, which is higher than normal, but these patients are really sick. Then you want to look at your oxygenation. So when we say an oxygenation goal, that means when you get your arterial blood gas, you want that PaO2 to be anywhere between 55 and 80 millimeters of mercury. And we said PEEP and FiO2, extra oxygen, are what help people increase their oxygen levels. So there's two different scales here. There's a lower PEEP, higher FiO2, and a higher PEEP, lower FiO2. And what that means, we're going to go to the higher one first, because right now this is what's being used in the hospitals with the COVID patients. That means you would go ahead and set your PEEP at 5 and an FiO2 of 30%. And if that's not working, if the PaO2 is still less than 55, instead of changing your oxygen, you would go up on your PEEP value to 8. Then you would go up to a PEEP value of 10. Then you would go to a PEEP value of 12. Then you would go up to 14. Then you would change your FiO2. So that's using a lot of PEEP. You can go all the way up to a PEEP of 24. So that's what these lower PEEP, higher FiO2s, and higher PEEP, lower FiO2s, these are called scales. So low PEEP and a high PEEP scale. So what's helping patients right now are proning and the higher PEEP scales. Okay, and then you want to maintain your pH, your acid-base status, between 7.30 and 7.45. And then I'm not going to talk to you guys about weaning and spontaneous breathing trials, just because you're not going to be familiar with those yet. We'll work on those next year. Okay, so we just talked about that, our pH and our oxygenation goal. If you guys can remember the AA gradient from last semester, it's the pressure difference between our alveoli and our arterial blood of oxygen. So it's your P big AO2. Anybody remember that equation? You were like, I hope that never came back, didn't you? So your P big AO2 is your barometric pressure minus your water vapor pressure of 47. Yeah. And that's multiplied, that's right, by your FiO2. And then you subtract your PaCO2 and multiply that by 1.25, which is your exchange ratio. And then you subtract that number by the PaO2, which you get from your arterial blood gas.
I was just about to say that, Jamie. You took the words
I
out of
knew it, Irma. I knew it. So if you have but I'm gonna show you guys a little trick. I'm gonna show you guys a really good app, so don't let me forget. Called MD Calc, and it even has this equation on there, as well as the PF ratio and the oxygenation index. It's got a lot of these that kind of helps you. So just remember, the wider the gradient, the bigger the number, the worse your patient is diffusing. Okay, so especially with ARDS, all of that fluid's going to really impair their gas diffusion. Okay, so I'm going to do a little demo here after this lecture on mechanical ventilation. Just remember that you want to use lower tidal volumes, higher respiratory rates, and higher PEEPs. Okay, so you want to give them more shallow breaths, but keep their lungs inflated, and then do lots more. You would do more than average respiratory rate just to blow off some of that carbon dioxide. APR bi-level, this is an advanced non-conventional ventilator strategy that we'll talk about next year, but your book even talks about the oxygenation index, and that's really talking about if people are, if it's beyond the, if it's beyond the PF ratio and you're using really high mechanical ventilation settings and you're not able to improve oxygenation, you may need to go to what's called ECMO. So ECMO is like a lung bypass. So if ventilation is not working, probably need to go to ECMO. So this is an index that tells you that your patient isn't doing well because it takes into account your mean airway pressure as well. So with the PF ratio, the higher the number, the better. On your oxygenation index, the lower the pressure, the better. And that's because we flip your FiO2 and PaO2. So I want you to understand this, but I'm not going to test you on the oxygenation index this year, but next year we will. But I want you to know very well your PF ratios. Okay, so PF ratios is, you are going to be tested on that and expected to understand that for this module. As I said before, prone positioning really helps because there's more area on the ventral, excuse me, on the dorsal surface or on the posterior side of your lungs. Also, the abdominal cavity and heart is not compressing the lungs, and it really increases the ventilation and perfusion balance. And that really leads to improved oxygenation and improved outcomes with these patients. Other therapies, neuromuscular blockade, meaning you paralyze them and let the ventilator do the work. Do you guys remember last module we talked about inhaled nitric oxide for pulmonary hypertension? Do you guys remember what nitric oxide does? I'll give you a hint. It works on the pulmonary vascular system. So it dilates your pulmonary vascular system. So it decreases the resistance in your vascular bed and allows blood to go in there and oxygenate better. And then if those strategies do not work, your patient is going to need to go on something called extracorporeal life support or veno-venous extracorporeal membrane oxygenation. So this is the bypass machine for your lungs. So here's a nice algorithm. So we look at our ARDS based on the PF ratio. We say it's mild, moderate, or severe. So if patients need mechanical ventilation, we'll use that ARDSnet protocol. And if that's still not working, we still have a low PF ratio, then we're going to go into prone positioning and maybe even paralyzing them. And if that still doesn't work, then we'll go in and use ECMO. They'll be a candidate for ECMO. Really in the hospitals at this time with all of the patients, they're seeing, you know, double to triple the numbers of ARDS patients they usually see. So I don't even know if ECMO would be an option for some of these patients. I just don't think they would have the resources available to give everybody ECMO. You guys have a question on this slide? So mechanical ventilation using ARDSnet, meaning we use lower tidal volumes, higher respiratory rates, and higher PEEPs. If that doesn't work, we flip them over into the prone position and maybe a paralytic. And if that still doesn't work, perhaps we put them on ECMO. Okay, so I'm going to stop there. These example questions are just, I did post the answers to them. These are what is going to be, these are examples of how NBRC is going to test you on ARDS-based questions. So I just put these in here for, just for some examples. I am going to give you a hint though on, you're going to have a quiz that's going to be due by next Friday. And that quiz will have one of these. And I'm going to give you a hint. You can find it by looking at your ARDSnet protocol. Okay. I'm going to get back into here. I'm going to stop the recording.